Wonderful. Thank you, everyone. So again, my name is John D. Capua. I'm a third-year medical student here. Today I'm going to be talking about a project that we put together through the Student High Value Care Committee titled Untitled Intervention to Decrease Necessary Folate Ordering in the Inpatient Setting. I obviously have no disclosures. This made me laugh having to put this in. I like that. So as we know, healthcare is very, very expensive. And one of the main drivers for healthcare expense is actually misuse and overuse in the inpatient setting. Overutilization is increasingly recognized as a potential target to reduce cost to the patient and health system, and also to reduce patient harm. And when we first created this group around 2 years ago, we were trying to think of, easy things that we can intervene on that would be some low-hanging fruit that we could kind of eliminate from our health system and try and improve value-based care. And the first thing that we thought of was actually folate lab testing, which is a common lab test that we all know about. The reason that folate lab testing currently is overutilized, you actually have to take a bit of a historical perspective. So in the early 1990s, in the United States population, around 6% of individuals were actually folate deficient. Because of that, the US government very wisely decided to enrich cereal grains with folate, which resulted in a precipitous drop in the rates of folate deficiency across the United States, actually all the way down to around 0.3% in the late 90s. And we actually can see this in NHANES data. So if we look at that dark black line all the way on the left, that is the average folate serum for patients that were enrolled in the NHANES study. And you see, and that's in the early 90s, and then the other lines are basically late 90s to early 2000s, and we see a steady stepwise increase in the serum folate lab values for patients that were enrolled in the study. There's also been a study that was directly looking at this in the inpatient setting. And if we look over here, starting in 2001, the number of patients who were folate deficient, which is defined as less than 3 nanograms per mil, was around 1.6%. And all the way down to 2011, that has dropped pretty significantly all the way down to 0.1%. So the problem that we're facing is that the prevalence of folate deficiency is actually extraordinarily low in the US population. However, we're ordering folate lab tests as if we were still in pre-1990s era, where the prevalence is actually quite high. So this was a pretty easy thing to conceptually intervene on and try and reduce the rates of folate lab testing. To do this, we actually had a three-pronged approach. So the first thing we did at the beginning of our intervention was to educate physicians and house staff in why not to order folate, and kind of the what our thought process was behind that. Second intervention, which was 7 months after the first, was to give targeted feedback to providers that were ordering folate lab testing. This is specifically in the inpatient, specifically in the internal medicine and hospitalist faculty. And then finally, we did an electronic intervention using in the EMR with both a best practice advisory and a removal of an order, which I'll talk about in a little bit. So first, our educational intervention. So this is actually a poster that we put in the residence lounge for internal medicine with the motto of "Don't be a serial folate orderer," with the idea that since the fortification of grain with folate acid, there's really no need to order, because there's you can replete folate levels very quickly with just a simple box of cereal. So we hoped we brought a little bit of humor to people's mornings. On the poster, you could also see we have some educational information. Study conducted at Beth Israel Deaconess found that around 2,093 folate lab tests were ordered. Only 2 patients were actually deficient, and in those patients, there was no change in management, so there was essentially no point anyways. So we gave a little bit of data, and then basically just saying, if you are concerned that a patient is folate deficient, just give them a meal, and they should be okay. So we hung that poster in the lounge for quite a while. We also handed out cereal boxes during sign-out, during morning sign-out. And on the cereal boxes, we taped these 2 little advisories. First, again, is just a summary of the poster. And then on the right-hand side, we have a picture of EPIC. And the reason we put this up there is that in our initial analysis, we found that a majority of the folate orders were actually done through this combined B12 and folate serum order. And it was our suspicion that people were typing in B12, and since it's the first thing that pops up, it's the combined order, they just clicked enter, moved on with their day. So our recommendation was don't order through this combined order. If you want B12, just order B12. That could reduce lab testing as well. So this is a photo of us handing out cereal in the morning. We had a lot of cereal that we handed out. Hopefully we gave people some nice breakfast. And this was the beginning of our intervention in December 2015. 7 months after that, so then in July 2015, we relooked at our data and decided to give the attending physicians in the hospital's internal medicine group personalized feedback about their folate ordering tendencies. So we essentially looked at the mean number of folate orders per physician across the entire group and compared each individual physician to the mean. If physicians were ordering above the mean, we very politely recommended that they no longer order folate because it's, as we've already talked about, not a very useful test. And if physicians were below the mean, we said, congratulations, good job, keep it up. And in both emails at the bottom, we again reinforced why we're doing this intervention, reinforcing essentially that the prevalence of folate is so low, there's really no need to continue ordering. If you're suspicious, you could just treat them empirically. And so that was our second intervention, again, 7 months after the first in July 2016. And then finally, our EPIC intervention. This occurred 10 months after the beginning of our study in October 2016. So again, like I had said, a large percentage of the folate lab tests were actually being ordered through this combined B12 and folate serum order in EPIC. So we worked with EPIC and the lab group to essentially remove this combined order. And that worked out really well, which we'll talk about in a moment. So we removed this combined order, and we also drafted some language for a best practice advisory if anyone were to order folate serum itself. Again, just recommending that we don't necessarily, we don't think ordering folate serum is actually a value-based care thing to do. And if you're worried that someone is folate deficient, you could let them eat or just supplement empirically. So that's essentially just a breakdown of how we did this intervention. And now, of course, as any project requires me to actually look at our data and see how we did. So our pre-intervention data is, we looked at folate lab ordering from February 2015 to November 2015. Our intervention data that we analyzed was from December 2015 to December 2016. And in our analysis, we looked at 4 trends. The first trend is that combined folate and B12 order that we have in EPIC. Second trend is simultaneous folate and B12 order, meaning I order single order folate and single order B12 at the same time, but they're technically separate lab tests. So we wanted to look at that. Finally, third is, of course, just single order folate, and the last one is single order B12. And in our analysis, we used a quasi-experimental interrupted time series with segmental regression. We also, on top of all this, kind of did a cost analysis, determining if we were able to actually reduce folate lab testing, by how much would we be saving the hospital. And to do that, we used a CMS data, and both the folate and B12 lab tests were priced at around $20 per test. So this is basically the raw data with the intervention time points put into the graph. So we see all the way on the left, pre-intervention, we were ordering around 95 to 100 folate lab tests per month on average. After the first educational intervention, we had a pretty nice drop, and that went all the way to July. After the personalized feedback, we had another drop, and then finally, after the removal of that EMR coupled order, we had our final drop. So we were able to go from around 95 all the way down to 15 on average folate lab tests per month. In table format, I think the biggest takeaway here is that we were actually able to reduce total folate ordering. So that's folate orderings from the three different trends that we analyzed. So total folate lab ordering by 87% from pre-intervention down to our final post-intervention. And this is the graph that we used from our segmental analysis, our time regression. And basically what we're looking for here, so the gray dots here on the left are the combined folate and B12 order. The blue is single order B12. The green is simultaneous folate and B12, so the separate lab tests but ordered at the same time. And the red is single order folate. And what we saw was a very large drop in the combined B12 and folate order from EPIC, which is what we were expecting. And then there is a compensatory rise in B12 ordering, which is again what we were expecting, because never in our intervention were we recommending not ordering B12. B12 is super important. We just don't want people ordering this combined folate and B12 order. And both of those change in slope were significant. Yes. So finally, with our cost analysis, we looked at, again, using the CMS data. Pre-intervention, we were costing the hospital with folate and B12 orders around $8,000 per month. And at the end of our intervention at phase 3, we reduced that cost to a little bit under $4,000 per month. So that's an over $4,000 savings per month to the hospital. Long-term data, so any intervention like this, you're a little bit worried about, is this actually going to continue over time? So this is folate lab ordering throughout the entire hospital. And we see after each intervention, we have a nice drop. And over in December 2016 is where we stopped actively intervening and just kind of trying to see how things would go. And we can see from here that the level of folate lab ordering across the hospital has actually remained pretty low, which is a really good thing. And we believe that's largely in part due to the combination of the educational intervention and the more, I guess, permanent EPIC intervention. We also have data from Mount Sinai Queens, because the way our health system is set up, if we remove the combined order from EPIC here at the hospital, and that also translated over to Mount Sinai Queens. And we see here that while not as large of a drop, because Queens, of course, did not have our educational interventions, there was still a pretty significant drop in their average folate lab testing per month, which has, again, been sustained since the EPIC intervention. So in conclusion, we were able to reduce folate lab testing by 87% with our intervention. The intervention was, again, a three-pronged approach, 2 educational interventions, one using just general education and bringing awareness to this issue with house staff and attendings. Second intervention was with personalized feedback to those attendings. And the last intervention was the EPIC intervention with removal of that combined folate and B12 lab order from the EMR itself. And with that, we were able to achieve a pretty significant drop in folate lab testing, which translated to a over $4,000 per month saving to the hospital, which is, for such a small test, it's a pretty nice drop. Some takeaways. I think that the educational intervention coupled with the lab intervention is really essential. I don't think you can have one without the other. Mainly because, as we saw looking at the Mount Sinai Hospital compared to Mount Sinai Queens data, educational intervention is essentially synergistic with any EMR intervention you can do. EMR interventions are fine. The only thing is, if you don't have enough stakeholders at the table when you do an intervention, if you do a EMR intervention that maybe is not satisfactory to everyone that may be involved, people will find workarounds. That's one of the reasons why we were looking at the simultaneous folate and B12 order, because our idea was if we remove the combined order, people may just order them both simultaneously anyways, and we didn't really do anything. So trying to get everyone to the table is really important. And EPIC interventions, of course, take a lot of time. There's a lot of people to talk with. We were working with our EPIC coordinator from the hospital medicine side. We were working with the lab group here and some other subspecialty physicians. And it takes a lot of time. We thought about the EPIC intervention really at the beginning of when we were first thinking of how to reduce this lab test. And it took us around 10 months to actually implement. So EPIC is very, very powerful, but you should definitely be prepared if you want to make any changes in there. And that's all I have. So thank you all very much. I'll take any questions.
Is there any economic incentive to order the two together? Like, is there a discount when they're ordered together? Or are they still $20 a piece, even when they're in the combined order? That's
a good question. I don't believe there is any economic discount when you order them both together. Maybe a driver for ordering them together was the assumption that maybe there was. I'm getting like a 2-for-1 deal kind of thing. But to my knowledge, there was no change in price if you order them together in EPIC like that.
All right. So for those of you I don't know, my name again is Benny Laitman. I am an MD PhD student here at Sinai, now finally in my last year of training. Student education has been a really important part of my time here, and so I'm really excited to talk to you about a project and program that I've worked on for a number of years. The program is called Preseason Pediatrics. It's a program, it's an interactive clinical curriculum that we've shown that enhances knowledge and skills in preclinical medical students. No disclosures to report on my end. So the objectives for this, I really just want to describe what is a novel preclinical curriculum in pediatrics. Really, this is not available in schools across the country. No one really does this. And explain how what we did is pairing resident-led didactics with hands-on clinical skills and how that improves student comfort and skill performance over time. So to begin, I want to take you back to 2011 when I was a first-year medical student, so not that long ago, but long enough. And I loved the coursework and all the faculty that I've interacted with, but I was feeling like I didn't have as much pediatrics exposure as I wanted. And in speaking with some of my classmates, anecdotally, they felt the same. A lot of our coursework in our doctoring course, the Art and Science of Medicine, and a lot of our preclinical coursework focused more on adult medicine. And indeed, across the country, that's generally the case. Medical students have limited pediatrics exposure in their first 2 years of medical school and really don't get it until their third-year clerkships. To see if this was a more widely held belief in medical students, we performed a needs assessment of graduating fourth-year medical students in 2013. And they were given a survey, first asking what their pediatric exposure was, and some of the results are on the right of the screen. And you can see it kind of echoes some of the anecdotal things I was hearing my classmates. At that time, students really were only about a third of respondents were exposed to pediatrics optionally in the doctoring course, Art and Science of Medicine. Others were exposed via pediatrics interest groups or shadowing, and a few others in longitudinal clinical experiences. When additionally surveyed if they thought an optional preclinical PEDS experience would have better prepared them for the clerkship, about 80% of the respondents felt it would. And also, would they have just found this exposure beneficial to their training overall? And about 90% of students felt it would have been a beneficial experience. And this is despite the fact the majority of respondents weren't even planning on going into pediatrics. So these results were our first step in creating an optional curriculum, which we called Preseason Pediatrics, or PSP. So the curriculum is as follows. It's a 6-month, 6-module first-year medical student elective that pairs monthly didactics with hands-on, resident-mentored clinical experiences where their skills are taught, where they go over skills pertaining to that month's didactic. Students are partnered with a resident at the beginning of the course that they work with during all their clinical exposures. And every month, a resident from a pediatric resident teaching group, which developed alongside our program, comes in and gives an hour-long didactic on a range of topics. And then students kind of are able to schedule on their own time in the intervening month when to go into the wards and work on some of the skills with their resident mentor. The topics that we had were newborn physical exam, pediatric development, pediatric nutrition, HENT and PEDS infections, dermatology, and then we ended with a residency panel to discuss things such as career advice. So how do we assess this curriculum and the efficacy of the curriculum overall? So we gave surveys to students before and after each course. So far, what I'm showing to you is data from 3 iterations of the course from 2014 through 2016. The course is still ongoing every year. That's about 40 students per year were surveyed. Students were given completed surveys before and after PSP. Knowledge was assessed using multiple choice questions pertaining to each topic covered in the course. And students were also asked to assess their perceived competency on the skills they were taught, and this was done using a 5-point Likert scale, with 1 being not at all competent and 5 being extremely competent. Additionally, we wanted to start looking at not only short-term knowledge and skills, but long-term maintenance of the knowledge, skills, and competency over time. So starting in 2016, which was the first year that our PSP cohort actually made it to the 3rd year clerkships, we began to survey students at the beginning of their pediatric clerkship and asked them about their perceived competency and comfort on the first day using the same Likert scale, and they were able to indicate whether or not they had participated in preseason pediatrics. To look at long-term skill maintenance, also starting in 2016, we began offering a newborn objective structured clinical exam 6 months after the first-year program to first-year students. And competency in that was done assessed by a single pediatrics faculty using a validated checklist. Statistics, we looked at differences between correct response rates using Fisher exact test. Likert scores were compared using Mann-Whitney non-parametric t-test, and p less than 0.05 was deemed significant. So our curriculum's gone through some changes, as with any course, over time. So we started off with our needs assessment back in 2013, and then went into a period of curriculum design. And the first iteration of the course was given in 2014, and based on a lot of student feedback, we went back and redesigned our curriculum. So in 2015, we actually removed a cardiology module that was in the first iteration of the course, and then added a dermatology module on pediatric rashes based on student feedback. In 2016, we added the OSCE to assess skill maintenance 6 months after the course, and also is our first year that we were able to offer our PEDS clerkship surveys. Currently, we've just completed our 2017 first year iteration of the course. The clerkship data from 2017 is also done, and OSCE, or from the last year was also done, and the OSCE is ongoing this month. So that round of data isn't included in this presentation, but it's what we're in the middle of. So what have we found? We had 119 students participate in the course over the past 3 years. Survey response rate from pre to post was 82%. You can see the individual response rates below. In the first year that we offered the OSCE, 9 students opted to participate in it 6 months after the course. In terms of clerkship response rates, 83% of third-year medical students filled out the survey, 116 out of the 140 that were eligible, and 49 of them had previously participated in PSP in the first year of the course. What we found on knowledge in the short term, when we examined this, we saw increases in percent correct response rates on all but one topic in our course, which was pediatric development. We asked a question, what percent of speech is understandable by age of 2? They did not improve their correct responses on that. For newborn physical exam, we asked what do the Barlow and Ortolani maneuvers test for. For nutrition, we asked which of the following is not a benefit of breastfeeding. For HENT and infectious diseases, we asked which of the following does not yet have a vaccine. And for dermatology, we asked at what age range is the rash erythematoxicum most common. And so with the exception of pediatric development, there was increases in correct response rates on all other topics. In terms of self-perceived competency on their skills, across the board, students felt more competent in their skills in newborn physical exam, developmental assessments, nutrition exam, head and neck exam, and dermatology exams. We also asked them about what they felt on their clerkship preparedness, and overwhelmingly 87% of the students felt they were going to be more prepared for their PEDS clerkship. In terms of skill maintenance, out of the 9 students that participated in the OSCE, 8 were assessed to be competent using a validated checklist, so this would be the same competency level of even a third-year medical student, so the fact that first-year medical students were already kind of up to that level was pretty encouraging. In looking at the third-year clerkship data, the early results we're finding is that those that participated in PSP compared to those that did not reported higher comfort levels with pediatric patients before even starting the clerkship. So what have we kind of found here? Overall, I think we've put together a novel, this is not really being done throughout the country, program that's successfully introducing students to preclinical and clinical pediatrics. The first 3 cohorts demonstrated that didactics paired with resident-mentored clinical experience improves their pediatric knowledge, clinical skills, and clerkship preparedness. And our curriculum really requires few resources, just has resident mentorship and a couple PowerPoint slides. This is something that can be adopted or adapted to other institutions pretty easily. So where are we going from here? Obviously, we're interested in following all the longitudinal data and seeing if skills and knowledge are maintained over time. So we're going to continue doing things like the clerkship surveys as well as the OSCE after each courses, and comparing those that participated in PSP versus those that did not, evaluating for things like comfort, perceived competency, and knowledge retention. We'd like to see over time, maybe does this impact clerkship performance, as well as does this even impact choosing specialties? The first cohort that actually took PSP is applying for pediatric residencies now, so it'd be interesting to see if that swayed them in any way. We've also expanded this to a second year of the course, so there is a PSP2, which is an extension of PSP1 where students can opt to take it. They are partnered with the same resident mentor that they were in first year, as long as their resident hasn't graduated and left. And it's there's no formal didactics in this, but it's supposed to teach them more skills to prepare them for clerkships. They go into the wards on their own time with their resident mentor. Each month has a different theme that they're supposed to kind of go over, like the heart exam or the lung exam. But there's no formal didactics. They are sent out monthly certain pearls of knowledge that kind of pertain to that month's theme. So that's basically it. I just wanted a couple thank yous. Sam Case, I think, is now here. Where do you go? Yeah. Oh, there you are. Hey, Sam is kind of taking on the torch to kind of move this program forward as the student liaison for Preseason Pediatrics. And since I've worked on this for many years, I really feel confident that he's going to do good things with this going forward. The two residents now, they were residents now attending, is Dr. Friedman, Dr. Mordler, who helped design the curriculum way back when. Of course, Dr. Mulbari and Dr. Gibbs, who've been incredible mentors supporting me over the years. And the PEDS resident teaching group, we couldn't do any of the teaching without those residents. And of course, the happy students that you see in the photo who participated, who this was all for. So that's it. I'll take any questions at this time.
Do they get a grade?
Nope.
For the course?
No grade.
Something on their
So this year, it's the first year we made it a Nexus sort of preclinical elective, so they can now have that indicated. Prior years they didn't. They can put it on their CV that they participated. But no, we don't give them. This is really just for them, optional participation and the love of learning. And we've had good participation. I mean, it ranges for about 40 students per year is a pretty good number for the class size. And there's not a lot of drop off. There's some drop off. They usually participate more in the first couple modules. Everyone loves the newborn physical exam, so that kind of keeps them engaged. But yeah, so.
But how did you decide upon the topics for the curriculum? Was that part of your needs assessment, or was there some sort of systemized way you came up with those?
So we tried our best to link it up with some of the things they were learning in their first year. So for example, PEDS infection, head and neck infection, infectious disease, they have the micro course. We tried to have newborn physical exams sort of because they had done embryology and things like, so we tried to link it up with things they had actually learned in the first year. And that's why we removed things like cardiology, which they don't really learn until the second year. PEDS rashes is kind of, we added derm because again, it kind of falls in the topic of infectious disease often.
Benny, the PEDS department has this wonderful program called the Pediatric Resident Teaching Program, so that's one great advantage in the program.
Yeah.
Do you have any way of assessing the impact of their participation as residents in a program like this?
Sorry,
And
so
the teaching residents who participated in this.
How was their
was it
teaching?
Optional, or was that part of their residency track that they have to participate?
Dr. Mulbari could probably answer that one a little bit better.
Speaks to that. So the PEDS resident teaching group is an optional group that residents can be a part of. In general, the pediatrics residency curriculum does include mandatory teaching things, that including a selective that all residents have to take in their third year. But this was optional to any resident who wanted to be involved, whether it be their first, second, or third year. And we had a nice cohort of about 15 to 20 residents each year who really wanted to be involved. And as Benny mentioned, concurrent to this course, to the PSP course, we sort of developed the PRTG, which is the PEDS resident teaching group, and Dr. Friedman and Dr. Mordler, who were residents that started the group, they actually are studying that and have done some work on that in terms of thinking about how does this benefit the resident to be a resident mentor, to act in this role, to teach preclinical students, most residents are used to working with clinical students on the wards, but how does it impact them in their own role as a mentor to work with preclinical students? And so it is optional, but they are involved, and they get some benefit as well. They get some, we do didactics for them, the faculty do didactics for them on, adult learning theory and, sort of teaching skills that they're getting outside of their mandatory teaching curriculum in the residency program.
As part of our survey, students were asked about their interactions with the residents, and many rated resident mentorship very highly, that they were as good as some of the faculty interactions that they've had. So the students that participate in our program really love working with the residents, and I think it gives them that that mentorship that's kind of more in their approximate age range and whatnot. So yeah. Thank you.